Good morning. We'll have a short discussion about the dry socket. Dry socket is the most common post-operative complications following the extraction of teeth. This term was first described by Crawford in the year 1896. Byrne labeled this complication as fibrinolytic alveolitis. It exhibits exposed bone that is not covered by the blood clot or a healing epithelium and which exists inside or around the perimeter of the socket or the alveolus for the days after the extraction procedure. There are several other terms have been used in referring to this condition, like alveolar osteitis, localized osteitis, postoperative alveolitis, alveolitis sicca dolorosa, septic socket, necrotic socket, localized osteomyelitis, fibrinolytic alveolitis. Coming into the definition of the dry socket, it is nothing but a post-operative pain which develops in and around the extraction socket, which increases in severity at any time between first and the third days the post-extraction, which will be accompanied by partially or totally disintegrated blood clot within the alveolar socket, may or may not be associated with the halitosis. Coming to the incidence, 3 to 4% will occur following the routine dental extractions, 1 to 45% after the removal of mandibular third molars, 25 to 30% after the removal of impacted mandibular third molars. It occurs 10 times more frequently following the removal of third molars than from all other locations. Coming into the incidence, alveolar osteitis, it affects the women more commonly than that of the male. Reason behind it is due to the changes in the endogenous estrogens during the menstrual cycle, since estrogens activate the fibrinolytic system in an indirect way in a females. So it is a reason why the dry socket is most predominant in female compared to that of the male. Coming to the onset, it mostly occurs 1 to 3 third days following the post-extraction. Within a week, between 95 to 100% of all cases of alveolar osteitis have been registered. The duration varies from 5 to 10 days depending on the severity of the conditions. Coming to the etiology, the exact etiology of dry socket or alveolar osteitis is not well understood. According to the Byrne, he suggested that the etiology of alveolar osteitis is an increased local fibrinolysis leading to the disintegration of the clot. There are few contributing and the risk factors for the dry socket, which includes surgical trauma, the difficulty of the surgery. It is due to the more liberation of the direct tissue activators, secondary to the bone marrow inflammations following the most traumatic extractions. And then another reason is mandibular third molar extractions. It is due to the increased bone density, decreased vascularity, reduced capacity of producing granulation tissues are the responsible for the site specificity. Systemic diseases, which includes diabetics, immunocompromised individual are prone to develop the alveolar osteitis due to the altered healing. Oral contraceptives. Increase in use of contraceptives have a positive correlation with the incidence of osteitis. This because estrogen has been proposed to play a significant role in fibrinolytic process. So it is believed to indirectly activate the fibrinolytic system and therefore increases the lysis of the clot. The smoking, the most important causes for the development of the dry socket. It is more common in a smoker compared to that of the non-smokers. And the physical dislodgement of the clot, it is caused by the manipulation or any negative pressure which is created via sucking an ostra would be the major contributing factors. Bacterial infections, the infections which is associated with the pericoronitis and the periodontal diseases. According to the Nitzen et al., he observed a high plasmin like fibrinolytic activities from the microorganisms, which is nothing Treponema denticola. Treponema denticola is a microorganisms which is present in the periodontal disease. That organism has a fibrinolytic activities, so which is one of the factor for the development of the alveolar osteitis. And coming to the excessive irrigations or the curettage. The excessive irrigation of the socket, it will interfere with the clot formation and then a violent curettage might injure the alveolar bone. Another reason, There may be a remnant of the root fragments or the bone fragments that will lead to the disturbed healing, which in turn contributes to the development of the dry socket. Local anesthesia with the vasoconstrictor. Since vasoconstrictor is used along with the lignocaine, that vasoconstrictor will increases the frequency of osteitis because of the temporary ischemia, which lasts for 2 hours and is followed by reactive hyperemia, which make it irrelevant in the disintegration of the blood clot. Coming to the pathogenesis, as I told, occurring to the burns, so that any of the traumatic extraction which cause the release of the inflammation of bone marrow and the release of tissue activators. Thus, tissue activator, which in turn convert the plasminogen to the plasmin, which in turn convert fibrinogen to the fibrin, which lead to the lysis of the clot. There are few direct activators and the indirect activators. The direct activators, which will get released after the trauma to the alveolar bone cells, and the indirect activators are the one which will be released by the bacteria. So these are release of the activators which converts plasminogen to the plasmin, which in turn converts the fibrinogen to the fibrin, lead to the soluble fragments. Since this fibrinolytic activity is a local, because initial absorption of the plasminogen into the clot limits the activity of the plasmin. Coming to the signs and the symptoms, the most common symptoms and the signs will be the pain and the tenderness in case of a sign, which will become more intense after 72 hours of the post-extractions. The pain, which will radiate to the ipsilateral, the same side of the ear, the temporal region, and the same side to the eye. Clinically, since due to the lacking of the blood clot, one can able to visualize the bare and the exposed bone. Regional lymphadenopathy, which occasionally the patient will be present with that. Unpleasant taste occasionally will be there, and the trismus will be present. So the trismus, which is nothing but the restricted mouth opening. So what is the main cause of the pain? So because of the formation of kinin in the socket, that kinin that activates the primary afferent nerves, which may have been already pre-sensitized by the other inflammatory mediators and allogenic substances. Even in the concentration as low as 1 nanogram per ml, that kinin will causes the pain in case of patients with a dry socket. Coming into the factors that influence the healing. So there are certain factors which influence the healing of the extracted socket, which includes the infection, size of the wound, blood supply, resting of the part, foreign bodies, general condition of the patient. These are all the factors plays a very important role in the development of the dry socket as well as in the healing of the normal socket. Coming to the preventions and the prophylactic management of the dry socket, which includes non-pharmacological and the pharmacological measures. Non-pharmacological measures, which includes use of a good quality, current preoperative radiographs, careful planning of surgery, use of a good surgical principles. Extraction should be performed with a minimum amount of trauma and the maximum amount of care. Confirm the presence of blood clot subsequent to the extractions. Coming into the pharmacological measures, antibacterial agents, antiseptic agents, antifibrinolytic agents, steroids, anti-inflammatory agents, abundant dressings, clot supporting agents. Antibiotic, which includes the penicillin, clindamycin, erythromycin, and the metronidazole. Even a local application of tetracyclines and also shows the promising result in reducing the incidence of alveolar osteitis. Pre and the post-operative use of chlorhexidine mouth rinse reduces the incidence of alveolar osteitis, especially after the extraction of mandibular third molars. Eugenol, it acts as an abundant, commercially it available as a dressing materials alveolar gel, which contains eugenol, butaben, iodoforms. The pack should be replaced every 2 days following the extractions. The topical application of hydrocortisone, oxytetracycline mixtures, it also shows an decreased incidence of alveolar osteitis. Tranexamic acid, it is reported to used to be prevent an incidence of the alveolar osteitis. Coming to the LLT, which is nothing but low level laser therapy, which is found to be a applied after the irrigation of the socket with a continuous mode diode laser irradiations. So using this will speed up the wound healing, reduces the inflammations when compared to that of the eugenol pack. There are certain use of prophylactic acid granules and oxidized cellulose forms. It also shows the reduced incidence of the dry socket. It is available as a biodegradable polymers, topical hemostatics, and oxidized cellulose forms, as I told. So it also, the usage of all these agents will reduce the incidence of the alveolar osteitis. Not only that, even a PRP, PRF can also be used to reduce the incidence of dry socket. Dextranomer, which shows a significant faster pain relief and decreases the incidence of the alveolar osteitis. So these are all the pharmacological measures to prevent the osteitis. Coming to the non-dressing management, remove any suture to allow adequate exposure of extraction site. Irrigate the socket with the isotonic saline gently, careful suctioning of all excessive irrigation. Do not attempt to curette the socket. Prescribe of potent oral analgesics, and the patient is given with a plastic syringe with curved tip for the home irrigations with the chlorhexidine solutions. Coming to the surgical management, which includes under the anesthesia, all the sharp margins, it has to be trimmed and it's to be rounded. If any of the foreign bodies, if it is present in the extracted socket, as I told, the root fragments and the remnants of the broken roots of the bone, are also the contributing factors, since they are all interferes with the healing. So if they are present, it has to be removed completely. Detached gingival margins are also scraped. The desired medications as well as the precautions should be given to the patients. The choice of the analgesic, which varies from the short course of NSAIDs to the narcotic-based preparations such as acetaminophen with codeine and the hydroxycodeine or oxycodeine can be given to the patients. Along with that, the patient was not only without the pain but also the comfortable both physically as well as psychologically from the very next day. So carefully you have to diagnose the condition, you have to treat the patient accordingly, either with a pharmacological or the non-pharmacological methods, followed by the surgical management as to be done. So alveolar osteitis is a self-limiting condition, so the cause which remains elusive. As I told, management should aim to relieve the patient's pain until the socket healing occurs. So healing is facilitated and accelerated through reducing the insult to the wound, either by the food debris or by the microorganism or by irrigating the socket with the chlorhexidine, followed by placement of medicated dressing and the prescriptions of analgesic. So the patient should be kept under review to check the socket is healing, especially if a dressing is placed. Ultimately, it is a host healing potential which determines the severity as well as the duration of the condition. Thank you.